Dr. Schievink come up again and reprise his role and talk about post-surgical complications.
I knew you were going to say that, but if you look carefully at this slide, it says post-treatment complications. And you'll see some of those. So, so we'll first talk about something that still, to me, really remains a mystery, right? And I think in some ways we underdiagnose it, and I think in other ways we kind of overdiagnose it. It's what we call rebound intracranial hypertension. And I remember really well the very first time I saw that, although I didn't recognize it at the time. And I was a resident at the Mayo Clinic. And we found this lateral leak. This gentleman had been leaking for, I think, 10 years or so. Took him to the OR, put an aneurysm clip over the leak. Leak was gone. I made rounds the next day, and I'm like, oh, I was really excited. I thought, oh, you must feel so much better. And he's like, no, doc, I still have a headache. And we were like, well, maybe there was a different reason. We sent him back to Iowa or something like that. And then about 4 or 6 weeks later, he calls and he says he's blind in one eye. And, we sent him to the ophthalmologist, and he had terrible papilledema, right, swelling of the optic nerves and a retinal hemorrhage. We didn't do anything. We didn't give him any Diamox, nothing. And then over the following 2 or 3 months, his vision totally came back to normal. So that, that really made an impression. But it wasn't until like years later that we realized, like, oh, that must have been some type of rebound intracranial hypertension. And then Dr. Mokri really, was paving the way to try to make people knowledgeable about this potential complication. Although I don't really consider it a complication of surgery or of treatment, I kind of consider it, it's a sign of success. We'll talk about that a little bit more later. And then Dr. Kranz and his colleagues wrote this great paper, about, I think it's now almost 10 years ago, where they actually would do a lumbar puncture after this rebound intracranial hypertension developed, something that I hardly ever do. And they actually documented that the pressure really was usually elevated. This is from Dr. Kranz's paper. So typically, but obviously not everyone, typically somebody with a spontaneous CSF leak, about half of them will say that the pain is sort of in the occipital, suboccipital, posterior neck region. And typically, but not always, when people develop rebound high-pressure headaches, it kind of migrates to more of a frontal headache. Sometimes it's not even just in the front of the head, but it's like in the mid-face. It feels like, sinusitis. So that's pretty typical. This is from a study we did a few years ago, and that basically showed the same thing, right? So before treatment, most headaches were either occipital, suboccipital, or generalized, and after treatment, most of the time, except for one patient out of, I think, 35 with rebound high-pressure headaches, all patients either had a frontal headache or more of a generalized type of headache. The other thing that we found is that it is more common in younger people, and for whatever reason, it's more common in women than it is in men. And we really don't have a good explanation for that. And from this study, we said that it happens about 1 out of 4 patients. It's a little bit untrue almost, because we only considered patients where we felt that we had to treat their headache with acetazolamide. So somebody who had like a mild, maybe it's high pressure, would not be included in this study. So only patients who had it to such a degree that we felt we needed to treat it with a medication that, as some of you might know, has a lot of side effects. And that you don't need to check somebody's lumbar puncture and do an opening pressure to make the diagnosis of rebound intracranial hypertension. And the other thing we looked at, and that was really the goal of the study, Dr. Farb has done a lot of work on the flow through the transverse sinus and how it relates to venous outflow obstruction and CSF pressure dysregulation. So what we did is we used this scoring system that was developed in the United Kingdom, where you look at the transverse sinuses, right? So those are large venous structures that drain almost all of the blood from the brain itself. And when it looked like there was no obstruction on both sides, we gave it a 0. If it was on one side, we gave it a 2. If it was on both sides, we gave it a 4. And what it showed was that if you have a high-grade stenosis, right, the group 4 on both transverse sinuses, then you're at a really high risk of developing rebound intracranial hypertension. And this is from a paper that was just published, and because I knew what Abe was going to talk about his crazy, like 10-level endovascular embolization. What was interesting about this paper is that they compared the occurrence of rebound high intracranial pressure type headaches following embolization and following surgery. And this is just a meta-analysis, so it's not really worth that much. But you can see that after embolization in this study, 26.5% of patients developed rebound high pressure, whereas with surgery, only 0.7% developed rebound high pressure type of headaches. Even though it says 0.7, that's an error because, of course, 5 out of 87 is 7%. It's not 0.7%. Nevertheless, I do think, and we've noticed that over the years that people who get treated with endovascular embolization are at higher risk of developing rebound than after surgery or fibrin glue occlusion. So what is sort of our treatment algorithm for patients who we suspect have rebound intracranial hypertension? I usually tell them, when they go home, just try to sleep on an extra pillow. If that's not enough, you can give them dandelion tea. Like 15 years ago or so, I had 2 patients from Los Angeles who are, they were very much into homeopathy, and they told me, oh, my rebound pressure headache was so much better with dandelion tea, and I didn't believe them, but there actually are some studies, and it's a mild diuretic. So if it's a mild case of rebound, I think dandelion tea might just be the solution. Some people really don't like the taste of dandelion tea. Then you can also take capsules, and apparently 2 cups of dandelion tea is better than 1 cup, but anything over 2 cups doesn't make any difference. Then, of course, there's the acetazolamide, methazolamide, right? These are really powerful, generally super successful type of treatments, but they have a lot of side effects. If people don't like those side effects, you can use, a whole bunch of other diuretics that usually doesn't work as well. If none of those are really effective, then sometimes we do a lumbar puncture, right? Not just to measure the pressure, but also try to release some CSF. I generally have either our medical student or worse resident do the lumbar puncture, because then they will, they'll try it 5, 6, 7 times, and then there'll be more drainage of CSF. If that doesn't work, then we might place a lumbar drain, right? So the problem with the lumbar drain, in order to place that, you have to use a really big needle. So a lot of patients end up with a persistent leak once you remove that lumbar drain. I think only once did we use an external ventricular drain. I don't remember the situation, but there was something with a lot of scarring or an infection of the lumbar spine. We placed an EVD. We've probably seen hundreds and hundreds of patients with rebound. I've only had to place a shunt twice. One of them was a patient who said, yeah, I just want to have a shunt, and that'll take care of it. And I went ahead and did that. And then a few patients have been treated with stenting of the transverse sinus with good success. That's something I don't know too much about. There was a time, also about 10, 15 years ago, that I would pre-treat everybody with Diamox, either before a blood patch or before surgery. It has so many side effects that I kind of went away from that. But some patients, right, who are knowledgeable, they say, could I please have a Diamox prescription before we go ahead with treatment. And almost always, would we say yes. So I'm also very much to blame about this, right? So if you do a blood patch, like Dr. Carroll does occasionally, on a patient where you really have no objective evidence for a leak, right? And they'll call you the day after, and they say, "Oh, I must have had a leak because now I have terrible rebound high pressure headaches." And I used to say, "Well, yeah, I think you're right? Your leak is fixed now. That's why you have rebound." Now, of course, everybody, right, who does not have a leak, when you do a blood patch and you inject enough blood, everybody will have a high pressure type of headache. So that's certainly not diagnostic of having had a pre-existing CSF leak. We've talked enough about surgery, so I thought we'd just go over some blood patch complications. Something that's very common, right, that's already been mentioned, is back pain, right? So particularly, right, so if you don't have a really large epidural space, right, let's say you don't have a dural tear, you either have a fistula or everything is normal, and you do a high volume blood patch, right, that will cause a lot of back pain because there's not that much space for that blood to go to. The other thing is arachnoiditis, and then occasionally a spinal cord injury. So this is from a study of patients who were treated by Dr. Louis. Charles Louis is an anesthesiologist that has been very instrumental in maintaining our CSF leak program. And he would do like crazy high volume blood patches, up to 130 milliliters. Now, unfortunately, his insurance carrier would not cover that. So what would happen is that he would place the needles, he would do the epidurogram, then he would call me. I would come out of the OR or clinic, and then I would be the one, pushing the blood in. We would never have a predetermined blood volume. We would just, keep on doing it either until somebody says, "Oh yeah, I feel a lot of pressure," or they get a radiculopathy, or, the pressure was just really high by the end, once we've delivered, 30, 40, 50 milliliters, and there was just so much pressure in the syringe that we stopped. But as you can see here, right, so particularly if you do a really high volume blood patch, right, most people will have a radiculopathy, they will have back pain. In this particular situation, like 3% of patients actually developed a CSF leak from the epidural blood patch. The other complication that we sometimes see is arachnoiditis, right? We talked about that. Dr. Callan did, is there a risk of arachnoiditis with glue versus blood? And I agree that it's pretty rare with glue, right, unless you inject it intradurally, of course. And then this is just a post-myelogram CT, and on the left side is what it looks like, right, in the normal situation. So you see all these little black dots within that thecal sac, right? Those are the nerves that go to your lower extremities. And then on the right side, you see how these nerves are totally clumped together, and this is somebody who'd only had 2 lumbar epidural blood patches done, somebody who didn't have any evidence for a leak. That had caused some really, horrible symptomatology. And then, spinal cord injury is really rare after a blood patch, but, it can happen. This is a lady who also had normal imaging, but she said, "Oh, I have a lot of pain in my neck." So I don't remember exactly what type of physician did this blood patch, but they thought, well, neck pain, then it's probably in the cervical spine. So they did a cervical epidural blood patch, and she woke up hemiparetic. She couldn't move the right side of her body. And as you can see here on the MRI scan, there's a perfect little, there's a little white area just where that needle went almost, to the middle of her spinal cord. And then finally, post-treatment recommendations. So we usually just have people, be in the recovery room for 4 hours, usually in Trendelenburg, right, because we'll do the blood patch in the lumbar spine, and as Dr. Carroll mentioned, right, thoracolumbar junction. Most leaks are in the thoracic spine, so we'll put them with their head down. Now, if they have a sacral leak, right, then of course it would be the reverse. I tell them that for a month that they shouldn't lift more than 10 pounds, no BLTs. For sexual activity, patients should be at the bottom. And I tell them the same, whether it's surgery or a blood patch or embolization. And that doesn't really make sense, right? So, for example, after embolization, I don't think you need to take all these precautions. And it also depends on the surgery, right? If it's like a long ventral leak and, you sutured it, but there was like maybe a little bit of seeping through one of the suture holes, right? Then I say, yeah, for a month you shouldn't do those things. But when it's just, a simple clipping of a nerve root, then, nowadays I tell them, yeah, you can go back to doing whatever you want after a week or so. And then, of course, there are special circumstances, and we haven't really been that good, except if it's like I mentioned, that fighter pilot. I was like, reading up on what is an F-22 fighter pilot supposed to do, or if it's like a baseball player that I find interesting, right? You kind of go further into the details of what it all involves, but you really obviously should do that for everybody that you treat, if only there was enough time. And then, the other thing is that a lot of patients are told that, they cannot take their anticoagulation after a blood patch. But of course, the patch is not connected to your blood circulation anymore. So we tell them that they can start doing that after 24 hours. I do tell them to avoid anti-inflammatory medication, because I think one of the reasons that a blood patch could work is that it, there might be an inflammatory response afterwards. And with surgery, we usually get an MRI before the patient is discharged, and particularly after intradural surgery, right, because you lose that turgor within the thecal sac. A lot of patients have epidural blood on their MRI. Then I tell them, they have to avoid anticoagulation for a week. But if the MRI looks really good, then I tell them they can start taking that after their MRI's been done. And then, if you want to know more about CSF leaks, exactly 4 weeks from now, we'll have our next conference in Amsterdam. Thank you.